Again, that's not a criticism, but it's a huge opportunity in partnership to say these people need us to do something different. And if by partnership working, by blending community resource and primary care, we can get those conversations around smoking happening, we can get people encouraged to take bowel cancer screening, we can either catch that earlier, in which case the health economy will invest less in the individual to get the same or a better outcome. Hi, my name's Adam Townsend. I am one of the founders of an organisation called IQVIA. When Angela said I got a fantastic population health presentation with loads of data in it, I heard a groan and I realised it was me. You'll be pleased to know I've got 30-ish slides. Only 3 of them have writing on them. This is one and the thank you one is the other one. So what I'm going to show you is a set of visualisations of data that paint a picture around, and I'm going to try and tell a story. Obviously, there's an oncology theme today, so I'm going to try and tell a story about that for the population of Greater Manchester. This is important. Every piece of data that sits behind the pictures I'm about to show you is free range. It's out there. It's in the public domain. We use it under license, but 5.5, 6 years of taming this stuff, it ain't easy. That's what we do. That's what we've been doing over the past 5.5, 6 years. But there is nothing in here which is patient level. There is nothing in here which is direct from provider. It's all open source data. So I think this, for me, is increasingly where we, as Angela said with the pharma companies, but increasingly, this is where IQVIA is offering the most value and support in understanding where the demand is coming for into our provision, and how we can support populations to manage themselves, to be supported better, more equitably. It is the only way we'll move to a more stable and sustainable health economy. This is for the Greater Manchester ICS. This is cancer performance dashboard. And as Andrew said earlier, I'm not going to teach you to suck eggs, but you can see there's a lot of decline in performance here. We've also got information. This pack's available, by the way, later and on your phones and iPads and laptops. Diagnostic waiting times are going up. Obviously, that's an impact on cancer pathways, and when cancer is taking the priority for that capacity, that'll knock on into elective pathways. But that's the story that gets all of the bandwidth, all of the news. This is what people are reading every day about acute provision and the pressure and the decline in performance as a result of that. But actually, there's another story that needs telling, that needs airtime, that we need to understand. And that's how can we get out into communities, understand their needs, support them better, and support the provision that's out there, including the voluntary sector, to wrap around the communities that have that need. Core 20 plus 5, it fascinates me purely because Core 20 plus 5, these things are not separate. Actually, the people that are experiencing these things typically are in there anyway. I'll show you an untypical example of that later. But fundamentally, understanding deprivation and how that impacts a population is as fundamental to improving the health and well-being of a geography as it is to understand deeply these 5 areas, plus whatever the ICS has chosen to embellish that with. I'm going to talk about early cancer diagnosis in the context of the 20% deprivation, and show you a golden thread, hopefully, that works all the way down from deprivation right down to what could we do about it, where's the opportunity, not to improve the acute performance, but to fundamentally shift the way that people are engaged in their communities. I appreciate you can't see the numbers on this, don't worry about it too much. This shows these little dots are every lower super output area. These are little geographies of about 1,500 people, for those of you that don't know, and everywhere's got them. So this is all of everybody's across England. This shows what the average deprivation indices is, and then the spread of one standard deviation. But what that says is you can have the same average deprivation, but you could have a very narrow spread of deprivation indices, or you could have a very wide one that's skewed one way or the other. And you can see here that average deprivation, Greater Manchester is the fourth most deprived area in England. However, with 1.3 million people living in the bottom 20% of deprivation indices, you are 200,000 in front of the next worst, and the people that were at the top, the Black Country and the West Midlands, are actually fourth and fifth. So in terms of pure numbers of people that you've got living in significant deprivation, Manchester is, the place where those opportunities need to be leveraged, and that check needs to be cashed the most. Underneath, we talk about deprivation, but we talk about the indices of multiple deprivation. Actually, underneath that lie 7 separate deprivation measures. And here we've just quickly isolated the 3 measures of, and I'm going to have to step in, I can't read that very well. So the education, training, health and disability, and crime. This is learning, so we can see across Manchester that actually, from a deprivation perspective, there's quite an even spread. This is a cumulative total, but we can see that crime and health are much worse, with many more people actually living in the bottom 20%. I've now gone down to local authority level, and we can see that, notwithstanding the great metropolis that we're studying right now, the difference in health deprivation of these 2 local authorities, and what we've got here is Salford versus Trafford, and I expect that this is no surprise to the people in the room, but fundamentally, in a world where our services have typically been smeared across a population on headcount, we can start to understand that, well, that's not necessarily the right thing to do when the need is so disparate. This is kind of a different picture of the same thing, where we can see that there are, across these 2 local authorities, there are just short of 250,000 people living in the bottom 20% of deprivation, and that's in England, not just in Manchester, that's in England. But the split of that is 2,000 of them in Salford and just nearly 30,000 in Trafford. So again, we've gone down the next layer, but just a different visualization of the same data to show the disparity even across a single ICS, let alone 42. And this is the same map again, but just showing as a heat map. And we're in Salford now, but again, we can see, really high levels of health deprivation in this area of Salford, and really less deprivation and a different population here. I'm just going to go a bit further into that, because this is patients on the cancer register. And I talked about showing you a picture where actually deprivation and health don't always align. And actually, cancer prevalence in this area is much lower than here. And the reason for that is that over here, you don't get to be old enough to die of cancer because the deprivation is so high. Which I can see there's 1 or 2 of you nodding, go, yes, we know that. But I think my experience of taking this into the broader ICS, ICP spaces is people don't know that. And actually, if you worked here a long time, you'd know that, but I don't. But when we can visualize that for people who are maybe part of a wider partnership, or colleagues that are coming into the organization who don't know the area, and say there's some things you need to understand about this, we're working on a model where we can actually go down to street level and put some virtual goggles on, and you can walk the streets of the area that you're interested in. But that's for we'll get this one right first. And just putting those side by side. So say high deprivation, low cancer. What we've got here though is I've just now gone into the practice process. So these little circles you can see is where we've mapped the GPs over the demographics. So each of these little circles is a single GP practice. We know quite a lot about that GP practice, and I'll show you that in a minute, but we also know quite a lot, for those of you that can see the presentation, we know a lot about the demographic of this little lower super output area. in terms of the age. And I think if those of you can see it, this is around 10% of that population's over 75. And in this little LSOA down here, it's less than 1%. So again, an ability to really understand the type of demographic, there's ethnicity data in there, long-term condition prevalence as well that we surface. But what I wanted to show you is the stark difference, because whilst we just said there is higher cancer prevalence in this area which has lower deprivation, these two practices that we're looking at are sizable practices. Sorry, I've gone. And I'll come to those in a minute. But this is the practice profile measure for bowel screening. So in an area where we know we've got less deprivation, these people, 74% of those that need bowel screening are receiving it. And in this area where we've actually got low cancer prevalence, but only 50% of people are getting screened for it, we start to ask the question, well, is it that we're not screening and that's why we've got low cancer prevalence? And that bit of actually, if we've got people who are potentially, because of their lived experience, being exposed to worse diets, is there an increased likelihood that at some point they'll develop something that could be prevented turning into a bowel cancer? I think these are the intelligent questions that you can start to ask. And then you can start asking the question about, so down here where we've got this real need where we need to make that better, theoretically that ought to be 100% in both. But if we can get this one up to 25% and deliver that equity against something that the government, the NHS, the GMC would all agree is a fundamental measure of cancer prevention because it's in the practice profiles, yet across a small geography, I don't know what the distance is from one end of Salford to the other, a 25% difference. I'm just going to drill in. So these are the two practices that actually sit in that little bit of geography that we talked about with the low bowel cancer screening. We know their names, we know a bit about them, we know quite a lot about them actually. We know their CQC rating, we know their GP staffing. So Blackfriars is one of the GPs that we just highlighted. Their GP ratio is up over 4,500 people per GP, and their FTE, their receptionists, is very low as well. And when we start to understand a bit about their long-term condition prevalence, and I'll touch on this in a moment, and accessibility, this is the Ipsos Mori data, we can see actually this is a very challenged practice in a very challenged area that isn't bowel screening in a geography where it's likely that obesity is very prevalent and that the type of diet associated with those kind of areas may well be driving people towards a situation where they're at higher risk. This is cancer management, long-term condition management markers from practice profiles. And again, we can see here, notwithstanding this one, which I've looked at, is a care home GP, it just does care homes. But this where we ought to be managing cancer really, really well is the worst of all of the GPs in the PCN. I just want to go to the other side of the patch and talk about lung cancer. So here we've got a practice that's struggling, requires improvement. 20,000, nearly 21,000 people registered at this practice. Salford Primary Care together. So even I can't see that now. So there we go. So again, really, really challenging numbers of patients per GP. And we can see that we've got challenges around long-term condition management. I'm just going to quickly flick to show these are the respiratory, but these are the markers about smoking cessation, smoking management. So again, when we're looking at lung cancer, if we're not having conversations with smokers about stopping smoking, the likelihood is that that's a group of people that are going to turn into the demand, which is challenging our acute provision, notwithstanding the poorer outcomes for the individuals. And we can see here, these score out of 10, each of these indicators, there's 3 in there, and they're all 1 out of 10. That isn't to be critical of primary care. As Angela said, it has its own challenges. But actually, if we understand where the need is, and we believe that historically, because of the locality model, because of the PCN model, where we perhaps put our community services across a population headcount rather than really understanding where the need is and migrating that resource based on need rather than headcount. Again, that's not a criticism, but it's a huge opportunity. in partnership to say these people need us to do something different. And if by partnership working, by blending community resource and primary care, we can get those conversations around smoking happening, we can get people encouraged to take bowel cancer screening, we can either catch that earlier, in which case the health economy will invest less in the individual to get the same or a better outcome, yeah, or we can prevent completely, dependent on how early upstream we are investing. And then there's just another one there, which is around the cancer management rather than the respiratory smoking for the same practice. These people need some help, and the people that they're registered at that practice need some help. So it's not, I'd say, absolutely not about being critical, but if we know that's where the need is, we absolutely should wrap our arms around these primary care functions, because there will be other areas where there are people like me, you know, where there are affluent areas where actually we've got intelligent patients, we've got people who are engaged with their own healthcare, who are easy to manage, who come and have their checks. Well, we could migrate some of that community resource into these areas if we just think about the partnership opportunity, having identified it in pictures. No one wants to see it. If you saw the table behind these data, put these pictures, it would make you cry. It makes me cry. My business partner, James, loves it. I can't be doing with it. I want the pictures. And just to say, you know, again, the numbers are too small on this screen, but fundamentally we can see, I've highlighted here the chemotherapy costs for the acute trusts in the Greater Manchester ICS. Many, many, many millions of pounds being spent helping people in really, really difficult circumstances achieve the best outcome they can, but coming all the way back, actually, if we go upstream and find these people, then maybe, just maybe, they won't have to experience that environment. And given the incredible cost of delivering these, you know, these interventions, just maybe there's more money here than we need to go there. That's it from me. I will make the offer to the room if you want to contact Chamber. We can replicate that pack for any local authority anywhere in England. So if there are groups of you in certain geographies and you'd like to see what that landscape looks like for your local authority footprint, we're happy to replicate that. The online portal that we've got just allows you as subscribers to change the drop down and print the image. That's all I do. So yeah, we'd be happy to do that.